Hello, my name is Ed Bottomley with the Michigan Medicine Department of Communication, and I will be your host for today's chat on metabolic syndrome. We're going to meet our panelists in a moment, but first, the mechanics of how to ask questions on here. You can submit questions at any time, even now, for our panelists to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video where you see it, but please note that your name or your profile name will be visible to others watching. If you prefer a more anonymous option, you can also send us a private message via Facebook or Twitter, or you can email us at ask-mishmed@med.umich.edu. If you can't stay for the entire chat or you want to share the recording with a friend, this will be available on our Michigan Medicine Facebook page, our Michigan Medicine Twitter account, and our YouTube page too. So let's meet our panelists. If we could just go down the line and have you introduce yourselves.
Sure. Hello, everyone. My name is Monica Tinkopa. I'm a faculty member at Michigan Medicine in hepatology, and I'm also board certified in obesity medicine. And my area of interest is in non-alcoholic fatty liver disease.
Great.
And my name is Barb Brimmer. I'm a graduate of the MetFit program, and it had a big effect on my life.
I'm Mel Rubenfire. Excuse me. I am the Director of Preventive Cardiology here at the university. My specialty is cardiovascular medicine and particularly preventive cardiology. We began the MetFit program something like 12 to 15 years ago, and it's been a delight to continue to be involved in it.
Fantastic. So let's kick things off with our first question. What is metabolic syndrome?
Well, the best way to look at it is that it is a difficult thing to understand from the perspective of a syndrome. We all know what a flu syndrome is. The flu syndrome is you have a sore throat, swollen glands, you have a fever, chills, and muscle aches, and that constellation or those things make up a syndrome. The metabolic syndrome is different. It's 5 different things that happen to people, each one of which contribute to the possibility of developing further problems, and they're under the aegis or the name of the metabolic syndrome. But the thing that ties them all together is having too much insulin because you're resistant to your own insulin. So it's also called the insulin resistance syndrome, which is what causes these metabolic changes that we'll talk about, I'm sure, soon.
Great. The next question follows on from that. You mentioned the word syndrome. How is a syndrome different from a conditional disease?
The disease would be a specific disease, like fatty liver disease. Fatty liver disease, Dr. Tinkopa is a specialist in it. Hypertension is an area that I'm involved in. So those would be 2 of the components of this metabolic syndrome. Hypertension is a disease. It's part of the metabolic syndrome in some people.
Next question that we have up. How dangerous is it to have metabolic syndrome?
Okay, I can handle this. So, in a word, it's not something that's dangerous at the moment. It's a lifetime of risk that develops because you probably have a family history of diabetes, so you're predisposed to diabetes, which is a serious problem. You may have a family history of hypertension, which might tie in. So the danger is having these 5 different factors, each one that contributes somewhat independently, but also together to increase the risk of diabetes, heart attacks, strokes, vascular disease, liver disease. All of those things are consequences of having the metabolic syndrome or this insulin resistance. So they build up on one another. You just don't have one. You might have 3, 4, or 5 of these criteria for the metabolic syndrome.
Thank you. Dr. Tinkopa, is metabolic syndrome a genetic condition?
It's always a difficult question to answer. There are some genetic conditions where we can say there's one specific gene that, yes, you have this, or no, you don't. Something like metabolic syndrome, and Dr. Rubenfire can comment more on this, there tends to be a family history. So people who have metabolic syndrome very often can say, oh, my mother, my father, my siblings, but there's not a one-to-one, like this specific gene will predispose you. I don't know what your thoughts
I
or
think that's
comments.
exactly right. It's the environment in which how we treat our genes. You know, some people will remain thin all their lives. They were predisposed to having diabetes because mother or father had diabetes, but they decided when they were young that they were going to always exercise and they were going to remain fit and they're going to eat all the right foods. They then may have prevented the genes from being manifest into this clinical syndrome. Whereas somebody who, when they were in their 20s, 30s, or 40s, started eating all the wrong foods, the family were all eating the wrong foods, they were very sedentary, didn't exercise, those are the people that would most likely manifest the genetic basis because the environment they're living in creates that metabolic syndrome from the previously birth-related genetics. We're not all destined to be the way our genes might be programmed.
Thank you for that. The next question, lifestyle. What role does lifestyle play?
So this is my favorite topic. So lifestyle is key, and that's really what we spend so much time in the metabolic fitness program, and particularly when I spend time with patients. As I said, my area of interest is in fatty liver disease, and that is the first line treatment. So it can be challenging because obviously lifestyle is everything that you do. It's what you eat, it's how you spend your time, but it's impacted by everything else going on in your life. And so, you know, that's why programs like MetFit that Barb can talk about a little bit later, you know, is really important, and why we're really trying to focus on that to try and help individuals improve their nutrition, improve their physical activity, because all of these things will help multiple different issues, whether it's liver disease, heart disease. So that's, you know, why we're here today.
Fantastic. Next question, if you have metabolic syndrome, how does that affect your health? Are you at higher risk for other diseases?
Do you want to start?
So the metabolic syndrome has disease within it. One of them is hypertension. That's probably the most important of the variables because if left untreated and unchecked, it continues and it predisposes to heart attacks, to strokes, to heart failure, to kidney failure. If you then add this idea of insulin resistance, what you get from that is an elevated blood sugar. The elevated blood sugar is associated with diabetes, peripheral nerve damage, eye damage, kidney damage, all the things that we all pretty much have heard about. And then in association with those is elevated blood triglycerides and low good cholesterol. The good cholesterol called the high density or HDL. Triglycerides are another form of fat. Between the two of them, they're both risk factors for heart and vascular disease. And they're also risk factors for the fatty liver that Dr. Tinkopa was talking about. So when you put all these five things together, they're all increasing the risk and they're all interrelated. What I didn't mention is what's known as truncal or visceral obesity, where you carry most of the fat. If you're overweight, you carry it in the gut. So just to put that in perspective, there are families who have generalized obesity where the whole family is very large, and that could be genetic, but they don't necessarily have diabetes or the metabolic syndrome because they don't have the insulin resistance. That's characterized with the big belly, and they might even be thin, but just have a big belly. So we're not talking about generalized obesity. We're talking about specifically obesity that accumulates in the belly, and that's because that high insulin level triggers the development of fat in the gut. It's known as the apple shape versus the pear shape of being overweight.
Thank you. The next question we have up, how does a person know if they have metabolic syndrome?
I think that's what makes this challenging is, you know, unlike certain things like diabetes or high blood pressure, as Dr. Rubenfire mentioned, it's a syndrome. And so there are 5 different components. Technically, you have to have 3 of the 5 to say definitively yes or no, you have metabolic syndrome. But part of the problem is a lot of the components are not routinely checked when you go and see your physician. So as Dr. Rubenfire mentioned, so one of the criteria is abdominal obesity. So it's not just what is your weight, what is your body mass index. You literally have to have a measurement of what your waist circumference is. And there's different cutoffs for men versus women. So you'd have to know that number. You would have to have a lipid panel checked. So as Dr. Ruppenfire mentioned, one of the components is what your triglycerides are. The other one is what's your good cholesterol. So if you have a low HDL, that's one of the components. Insulin resistance, and then hypertension. And so it becomes very challenging unless you are systematically going through each of the criteria for you as an individual to know, yes, I have this, or no, I don't. And so then, again, that's in part what we're trying to do in terms of, educating both patients and providers. These are the components. This is how you can figure out whether or not you have it, and then how does that impact your risk of other conditions.
Fantastic. Next question we have up, can treating my metabolic syndrome help my diabetes?
Well, it definitely can help your diabetes. Even more importantly, it can prevent the onset of diabetes by many years. Not guaranteed, of course, but if you are diabetic, the diet and the exercise are both extremely helpful in reducing that insulin resistance and the need for insulin. So your pancreas doesn't have to work as hard. As a diabetic, your pancreas has to overwork because you're resistant to the insulin. And then once your pancreas burns out, then you need insulin. So if early in the course of diabetes, you can join a program like this, or any effort that you can make with weight control and exercise on a regular basis will reduce the blood sugar, will improve the risk factors that are associated, or reduce the risk factors associated with diabetes.
What about liver disease? Will that be helped by treating metabolic syndrome?
100% yes. Like I said, this is what I try and spend most of my time on. And even though non-alcoholic fatty liver disease is so common nowadays, the good thing about it is if we catch it early enough and we can really get, focused on healthy eating, regular physical activity, we can completely reverse the condition. And so that's what we try and really emphasize. This is a curable condition so long as we, kind of identify it early enough and kind of go down the path to work on all of these different components of metabolic syndrome.
Great. And next question is with regards to nutrition. How important is nutrition in the treatment of metabolic syndrome?
So as I kind of mentioned at the outset, I was very interested in trying to learn more about nutrition and exercise because as a gastroenterologist and hepatologist, that wasn't necessarily part of my training. So I did this whole, kind of board certification in obesity medicine. And one of the key things that I learned that I feel like most people aren't as aware of is that 80 to 90% of weight loss is actually nutrition-based. Which is good and bad. So it's good in that if you have barriers to getting regular exercise, whether it's time, money, or other kind of chronic conditions, even if you can't regularly exercise, but you do a very good job of being cognizant of your nutrition, you can still achieve all of the important kind of weight loss endpoints. That being said, exercise has multiple benefits for multiple different conditions, and so we still continue to emphasize that, but nutrition is very key.
Perfect. And follow up from that, is there a special diet or a healthy eating plan for a person?
So that's a very, depending on where you read, everyone has their own opinion. That being said, we have done a couple different studies looking at this, and in our metabolic fitness program, the diet that we tend to emphasize is a Mediterranean diet. And so a Mediterranean diet has been studied specifically in cardiovascular disease, it's been studied specifically in liver disease, and across all of those studies, there have been pretty definitive results showing that it benefits all of the components of metabolic syndrome. So that's by and large what we really focus on kind of in our program participants. The other one that we spend a lot of time in is more a carbohydrate controlled diet, and that in large part has to do with the fact that a high percentage of our patients have diabetes, and so that's very often recommended for that condition.
Let's move on to stress. How about the role of stress in metabolic syndrome?
I think stress is, it's the scourge for all of us. We all have stress. But some of us are predisposed to stress-induced eating. Some of us avoid eating when we're under stress. So I think the binge eating associated with stress is one of the big problems that we see. And stress hormones include cortisol or cortisone. You all probably are familiar with that. That's what you take if you've got certain diseases. It's the so-called stress hormone. If you're under stress, that cortisol or cortisone actually increases from the adrenal glands and that gets you more hungry. So there's a tie-in between stress, cardiovascular disease, hypertension, eating disorders. All of them tie in very, very well, unfortunately.
And how about exercise? How important is the type or the amount of exercise in the treatment plan?
So as I mentioned, exercise remains very important. So it's not a primary way to achieve weight loss, but even in the absence of weight loss, it can help improve all of the different components of metabolic syndrome. And so again, just like diet, everyone has their own opinion about this type of exercise is better, or this type of exercise is better. And it's a hard question to answer with data just because it's a difficult thing to study. So usually what I say is find an activity that you're interested in, find an activity that you're going to continue to do. Because if I tell you to go and ride a bike and you hate riding a bike, then that is not a useful piece of recommendation for me to give to you. So, in our program, we try and help tailor the different activities to, and Barb can talk about this, what you're interested in doing, what you like doing. And so we do different things. So there's resistance-based exercises that you can do even if you have a lot of other physical kind of limitations, whether it's musculoskeletal or what have you. We have more aerobic exercises. And so I think in general, more aerobic-based exercises tends to have a higher efficacy for weight loss, but whatever type of exercise you do is still very beneficial.
Sure.
So Monica's, Dr. Tinkopa, you can call me Mel here so everybody will be
We're fine.
The type of exercise is important, particularly the exercise that you enjoy doing, but there's a couple things that have been shown with the metabolic syndrome to prevent it as well as treat it, as well as almost all conditions if exercise is part of the therapy. And that's actually that more is better. The number of minutes or hours you do in a week are really quite important. The idea of doing somewhere between 200 and 300 minutes a week is what we generally talk about for weight loss and the metabolic syndrome. It's very hard to do 300 minutes, an hour, 6 days a week or 5 days a week. But you can break that up. It doesn't have to be continuous exercise. It can be 15 minutes, 3 or 4 times a day. There's something else that many people watching might be familiar with, which is called high-intensity interval training. High-intensity interval training can shorten the amount of time that you use during your daily exercise, and you can split that up. Basically what it means, if high intensity is maybe like 90% of what you think you could do, and if you did any more than that, you'd get exhausted in a minute or two. So doing something like 2 to 4 minutes of high intensity, meaning at 90%, and then going back down to 50 or 60% for 3 or 4 minutes, you just go back and forth like that. You can do in 20 minutes what normally would take 40 minutes. So that, and you can read about this. The internet has everything we're going to be talking about, but high intensity interval training is something that's very good. And as was said, the larger you bulk your muscles, the better muscle strength you have, and the better bulk you have, you're going to, when you gain those muscle mass, or the muscle mass, you're going to lose some fat mass. And it's that muscle mass that metabolizes the glucose and the triglycerides. Muscles do a lot, it requires a lot of energy to build those muscles and use them. So the more muscle strength building there is at the same time that there's aerobic, the better. Sorry, I should have turned my cell phone on.
It's fine. So our next question, can you reverse metabolic syndrome? And if so, will it come back?
So that's a very important and disappointing question. Disappointing, and it does come back. In our 6-month program, we have a very, very good percentage of people who lose one or more criteria of the 5 criteria. The blood pressure comes down really quickly. Within the first 2 or 3 weeks, people are coming off of a medicine when the pressure comes down. Triglycerides come down. The body, the visceral obesity or the waist dimension comes down, and the blood sugar can be moderated. The HDL cholesterol doesn't do too much. At the end of 6 months, people are really doing pretty nicely. Unfortunately, while they are told, this is going to be the tough part, we're going to get a divorce at the end of the 6 months, and you're going to be on your own. Many, many people do not continue what they have been taught, even though they've spent money doing it and they've really enjoyed doing it. Once they're through with the program, They slow down, and we all do this. It's the New Year's resolution. New Year's resolution. Every year we're starting another one. So that's what's going on with the program. We did some very elegant studies that we published, and Dr. Tincombe, myself, and some others in our group continuously do research on what we're doing, how we're doing it, how we can improve on it. And what we found is at the end of a year to a year and a half, a great majority of the benefit can be lost. Not everybody, but it's unfortunately at least half the people lose a significant amount of benefit. Why? Because it's not magic. You got to keep it up. You have to keep doing what you learn to do. And what we know is that it's hard to change behavior. What we've experienced is that 6 months is about right to get rid of the carb addiction. So most of the people are carb addicted, and you can get rid of that in about 3 to 6 months. But it doesn't take more than a few weeks to lose some of the benefit. The blood pressure can come back up within a month or so. It takes only a few weeks to come down. It takes only several weeks to come back up. So you have to be persistent. You have to enjoy it. You have to be in love with that new person that you become.
Thank you for that. Let's move on to a few questions for you, Barb.
Okay.
My first one, tell us about how you found out that you had metabolic syndrome. How was the diagnosis made?
With my primary physician. I had already been diagnosed with high blood pressure. I had good cholesterol except for my HDL, which was way down there. And I had then been diagnosed as pre-diabetic. And that's when he said, you know what, I think I have a program for you. And he started to tell me about it. And I made the phone call and went in, joined the program.
So the next question I have for you is, what did your doctor do to treat you or recommend that you do?
Well, he had me on medication.
Sure.
And then he recommended the program. He knew about it. He had seen success with it and said, I really recommend you do this. And I took him at his word and I did it.
Could you tell me a little bit more about the program?
It's changed me so much. It's changed my life so much. But I'm kind of laughing at you saying, you go off of it. I had to get my head around it to realize this wasn't just a temporary thing. This was a new lifestyle. And it took me probably halfway through the first 12 weeks to kind of get that in my head. And at that time, I was starting to see some changes going on, and I'm thinking, oh, this thing is working if I just keep at it. And another thing, I'm still laughing at some of the things you said, because you're saying more is better. I was starting with 3 days a week exercise, and I started thinking, well, if I'm seeing changes, maybe if I do more days a week, I'll see even more changes. And so I've been exercising now 5 days or more a week because of that, and it's really helped.
Fantastic, fantastic. Next question that we have up, what did you think when you started this program? Were you optimistic?
Not at all. Not at all. I would have placed a bet on I would have dropped out within the first several weeks. But then I started to see changes.
Sure.
And that gave me motivation to say, this can happen, this can be done.
So when we talk about your initially you didn't have optimism, what were the biggest challenges and obstacles that you faced?
I was not an exerciser. I had had knee problems, and I had been, in my head, if I was exercising, it was hurting my knees because my knees were hurting. So I thought I was being good to myself by not hurting the knees. What I found out is doing the exercise is making the knees feel better and helping the knees. If I had known that 20 years ago, I might not have needed this program. But, it was finding out things like that.
What do you think was the most surprising thing that you found out about the program and about yourself?
that I could do it. That's the biggest thing. Because like I said, I thought for sure this would not be a success. But it has. The program, the teaching part of it is good. You're not being fed, you've got to have this food and this food and this food. It's here's it, and work with it, and work with our dietitians to put it together for you, for what makes sense to you and what works for you. You don't have to eat this day and this day, and it becomes a way of life as opposed to a, quote, diet, that you then reach your goal, you stop the diet, and then the cycle continues again, unfortunately. So it was a surprise to me that I could get that to work for me. Mm-hmm.
Sure. And in terms of results, what kind of results did you have in terms of health, medication, increased energy, things like that?
No medication. I'm off the high blood pressure. I'm off the pre-diabetic medication. My HDL is way above what it's supposed to be. My knees are feeling so much better. I mean, it's changed a lot.
That's fantastic. And how about motivation? How have you stayed motivated? What fitness goals do you have for yourself? I think I heard something about a 5K maybe?
Yes, there's going to be a 5K. I don't know what its official name is in April. And some of us in the fitness center are training to be in the 5K in April, and I'm going to be there.
What do you think you learned about yourself during this?
That I could do a lot more than I thought I could, that I could stay on the right track and have a success at this. Like I said, I thought I would be out weeks, and I'm still going to the gym.
I tell you what, I have a great view here because I can see you saying stuff, and then I can see smiling. How about people watching? What advice would you give to others?
To others, I'd say if I can do it, they can do it. You can do it. I like I said, I had to get it in my head that this was really a new way of life, or a new way of doing things. But, and in my head, it's now, that's my job. My job is to go to the gym, my job is to watch what I eat, and that's my job. And that's how I kind of deal with it day after day. But I really feel if I can do it, and I can get into that routine, if you really try, and I don't want to make it sound like it's easy, because it's not, but it's doable. You just have to commit to it.
Fantastic. That's excellent to hear.
Does the audience know the content or what's in it, what it means to be a patient?
No, let's talk a little bit about that.
So you have to be physician referred, and Barbara was saying that her physician called it the metabolic syndrome. A lot of our physicians wouldn't do that, and I wouldn't say more than 20%, at least in Michigan medicine, know about MetFit. So being conscious of the fact that if you have high blood pressure and a family history of diabetes, you may well have the metabolic syndrome already. So saying to your physician, if you have hypertension, or you have an elevated blood sugar or high triglycerides, those things that we've talked about, if you have any one or two of them, you should be asking your doctor, could it be that I have that metabolic syndrome? And they'll say, well, yes, that may well be the case. Is there anything I can do about it? I heard about MetFit. Well, most of them probably would say, I think I do recall that. But it's very easy to go through that process. But you have to be physician referred, and you got to be able to think. The physician's got to think about that. Once they're referred, they go through a process of acceptance, which requires laboratory testing. There's an exercise stress test to be sure, for people who are not fit, to be sure that they can do the exercise. And there's a psychological profile. A lot of things go into it. Why a psychological profile? Because we want to be sure that somebody is seriously depressed doesn't go into the program and not become successful. But it doesn't mean if you're depressed you can't be in the program, because we've actually studied it and shown that depression is not a reason that you can't be successful. We screen for sleep apnea, which is a very common phenomenon. The sleep disordered breathing with the snoring and stopping breathing at night is very commonly associated with it. Why do we do that? Because that diagnosis of sleep apnea, if you treat it, you might be able to remove some of the criteria for the metabolic syndrome just by treating sleep apnea. So once you're in the program, it's a 90-minute program once a week for basically 6 months. People usually enroll for 3 months and then want to extend it for 6 months. Some enroll for the whole 6 months. The program of 90 minutes is 45 minutes of a discussion, a group discussion with that includes some lectures and discussions, and the other 45 minutes is exercise in a very, very good aerobic center. The aerobic center has every kind of exercise equipment you can imagine, and they teach yoga. If you want to do yoga, there's all sorts of wonderful things that can be done. There's equipment there if you have bad knees. There's equipment for that. If you treadmills, essentially everything, weight, stretch equipment, and then they teach you based on your own energy requirements, and they teach you based on your strength and your endurance and your history of exercise, just what's right for you. So it's very, very one-on-one. There's about 5 staff there, including certified exercise physiologists and some interns in exercise physiology, and they're very well versed in all this. So that's the 6-month program. And then within that, there's an opportunity to go to a cooking class that the university has on the East Campus, and it's in that particular class it's geared towards the metabolic fitness program or the metabolic syndrome. So then you learn to sample foods, and you begin to get recipes to prepare foods. Of the lectures or the group discussions, it's everything that you might imagine, from stress and behavioral change to liver disease and how that ties in to the consequences of diabetes. What are triglycerides? What can I do? And there's experts in nursing. There's pharmacists. There's hepatologists. Dr. Tinkopa does it. I used to do it, but they got tired of me. And basically that's it. So, but then at the end of 6 months, we're just now beginning a transition to a follow-up program. And Dr. Tinkopa and I worked very hard with Sam Fink, who's the lead of the program, to try to design things. And what we did is we reviewed the medical literature, everything that was available in medical literature in this country as well as other westernized countries throughout the world, and found very little was done to treat the metabolic syndrome. And there was very little good scientific evidence as to how to design it. But we took everything available, and now we're going to be doing a follow-up program where people come back to see us and join the program, but just at 1 month, 3 months, 6 months, and a year. And very soon, if things work out the way we think they will be, we'll be designing a new program where there'll be communication by Facebook or Skype. We're going to have patients wear a Fitbit, and that Fitbit will tell us how much exercise they're getting, how much sleep they're getting. We'll have electronic scales that, with Bluetooth, will send information back to us. Very exciting stuff. This is cutting edge. This is the next thing. Apple is working, the iPhone folks are working on some pretty sophisticated things. These are actually the next level. This is something that we're going to be testing out here that'll be available clinically probably in a couple of years. Very exciting new things. So if people are joining the program soon, that's one of the opportunities they may have.
Thank you. I had about 5 questions, and you went and answered every single one in a row. It was fantastic. So with regards to the MetFit program, how much does the sense of community help make patients successful?
It was a huge part for me, and I think it is for everybody else. You're all going through the same thing, and you have commonality, and it really does help to talk to others doing the same thing.
Fantastic. That was by design, presumably, to have
Totally by
everyone.
design. It's not a lecture, it's a group discussion with a discussion that's based on 10 or 15 minutes of concrete discussion concrete evidence-based stuff, that leads then to everybody saying, well, wait about this and what about that? Occasionally in some of the classes, the same person, like I'm talking too much, the same person asks too many questions. But I wanted to get back to something that we covered. Somebody asked about stress. So stress and depression are two of the things that can interfere with the success. If you've gone through the program in 6 months and everything is good, and suddenly your son or daughter has an illness, or your grandchild is ill, it is so easy to get off that whole program. You stop exercising, your priority is no longer you, you're eating all the wrong foods. Same thing happens in a funeral. You know, you eat a lot at a funeral. You try to, make the family that's suffering. You bring food, you bring cakes, you bring whatever. So it's very important with a program like this not to let things in life get in the way of keeping yourself that same person. That's the big problem. Sometimes holidays are great. Sometimes they're the worst thing in the world. Sometimes people get depressed during Christmas because the family's not there. Or sometimes they eat too much with a wonderful family. So people in the program learn that it's very easy to go off the program with all of these various stressors, or sometimes happy, sometimes very sad things. It's very difficult to stay on track.
Thank you for that overview. We're moving now to non-alcoholic fatty liver disease. Dr. Tinkopa, we mentioned it earlier. What exactly is non-alcoholic fatty liver disease?
Perfect question, thank you. So non-alcoholic fatty liver disease, as I had mentioned briefly, is very, very common. We think up to 30% of all adults in the United States have it, and the vast majority of people have no idea that they have it. So essentially what happens is, in the setting of having all of these metabolic features of metabolic syndrome, fat will start depositing in the liver. Fat can serve as an irritant, so over time you can get inflammation. If you have enough inflammation, you can get scarring. If you get enough scarring, you can develop cirrhosis. Once you have cirrhosis, there's a whole list of bad things that can happen to you. That being said, of everyone who has fatty liver disease, at the end of the day, probably only about 5% of people will end up getting significant liver disease, which is why currently there's no recommendation to screen for it, and why so many people don't know that they have it. But as I said, it's a very, very common condition that we essentially see in the setting of metabolic syndrome.
Okay, and how is it diagnosed, and what are the symptoms?
So also very challenging questions. So for the most part, there are no symptoms, which is why people don't know that they have it. In terms of how we diagnose it, that can also be quite challenging. As I said, right now, there's not a recommendation to screen individuals, even if you have multiple risk factors that make it likely that you have fatty liver disease. So generally, the way that patients end up coming to see me in the clinic is they'll have blood work checked for some reason, and they'll be noted to have elevated liver enzymes, or they have imaging for some reason. And on the imaging, usually an ultrasound, but it can also be like a CAT scan or an MRI, they'll comment, that there's fat deposit in the liver. And so usually those are the two most common ways that people come to know that they have fatty liver disease.
In terms of screening, should patients ask their physicians to be screened for liver conditions?
Yeah, as I said, it's a tricky question, and I think the answer to that question will likely change in the not so distant future. As I said, right now, our Liver Society has said that they do not recommend screening individuals for fatty liver disease, even if you have, multiple risk factors. Again, just because so many people have it, we don't have evidence about cost effectiveness, and at the end of the day, only a small proportion will have significant liver disease. At the same time, we recommend that people should be, aware about the condition, and that, physicians who see patients with these risk factors should kind of have a high level of suspicion. So if you're concerned about it, we try to give recommendations in terms of if you're concerned that your patient has fatty liver disease, these are the tests that could be potentially helpful, and these are the patients that we think would most likely benefit from then coming to see a specialist about it.
Okay. We have a few more questions about non-alcoholic fatty liver disease. Can you remind us of fatty liver disease's connection to metabolic syndrome?
Mm-hmm. So as we kind of went over, the liver, everyone always asks, well, what does the liver do? It's a very difficult question to answer, but one of the major jobs of the liver is, is kind of the metabolic powerhouse of your body. And so in the setting of having insulin resistance and all of these changes in terms of your lipids, abdominal obesity, what happens is your metabolism essentially gets out of balance and your body will start depositing fat in the liver. So it's generally individuals who have abdominal obesity, have insulin resistance, have high triglycerides will develop this condition. And so that's how the two are directly linked and how a hepatologist ended up working with Dr. Rubenfire in this program.
How do you treat non-alcoholic fatty liver disease?
My favorite treatment. So as I said, I spend the vast majority of my time really focusing on lifestyle changes. So predominantly healthy eating habits. I try to be very cognizant of not saying diet. Healthy eating habits and increasing physical activity. So right now, there are no FDA-approved medications to treat non-alcoholic fatty liver disease. That may change as soon as a year from now. If you go on to, if you Google medications to treat fatty liver disease, there's over 200 different clinical trials. But right now, there's nothing FDA approved. So there really is the cornerstone of therapy is working on these very difficult challenges of working on healthy eating habits, increasing physical activity targeted towards weight loss. And the reason we do that is that studies have shown if you can lose 3 to 5% of your body weight, the amount of fat in the liver will go down. If you can achieve a 7% reduction in your body weight, fat and inflammation, if you have inflammation, will go down. But then the magic number is 10%. So if you get to 10% reduction in your body weight and you keep it off, fat, inflammation, and scarring can go away. And that's why I said it's amazing, because if we catch it early enough, it's completely curable.
And healthy eating habits as opposed to diet, because the implication is diet is a temporary thing?
So I say diet and people like cringe, right?
Okay.
Like nobody wants to go on a diet.
Yeah, sure.
And as Barb said, like diets tend to be kind of these things that you do for a fixed amount of time. I tell you you can eat this, you can't eat that, and that's it. Whereas healthy eating habits are more of a total different
Lifestyle.
approach to what you do all the time. It's not something I'm going to do for, my 2-week cleanse or what have
Sure,
you. So
sure.
that's why I try to avoid diet, but really the focus is like everything that you consume in terms of the choices you make.
Fantastic. Can non-alcoholic fatty liver disease be reversed?
Yes, 100%.
Excellent. You know what? It looks like the next question that we have is probably my favorite one for the viewers. It's probably the trickiest one for you guys. What would you like people to know as a takeaway about metabolic syndrome, about its impact, about its treatment? If somebody was tuning in just now, what would you like them to take away from this?
You want to go first?
Well, for me, I would like people to know that it can be changed. You can change that part of your life. The exercise was so important. The food is so important. And just getting your head around, I am going to make these changes. I think we're all worth it to do that.
Fantastic. Dr. Tinkova?
I guess like my first thing I would say is one, to know that it exists, because as I
Sure.
said, I feel like metabolic syndrome is this nebulous concept that a lot of people, one, don't know what it means, and two, as I said, it can be very hard to diagnose. But 100% what Barb said, the major thing is that even though you may have all of these components and that if you don't do anything about it could lead to all these chronic conditions, that it is completely treatable and there are things that we can do to address each of them. And it's really kind of getting to that point where you buy into it, because so often, you talk to patients, they're like, well, I know what I should be eating, I know what I should be doing, I don't know how to get there. And so it's getting to that point where you're like, okay, I know what I should be doing, I now have the confidence that I can do it, and now that I'm doing it, I have the confidence to keep doing it. And it's possible.
It is.
Fantastic. Dr. Rubenfire?
Those are all what I would have. I took all mine. but the idea is to be aware of it. That's what you're listening to this for, and that awareness should trigger this idea of discussing it with your physician. Because as we were saying earlier, if the physician doesn't buy off on it as his or her responsibility with you to share in that, you're not going to get anywhere. Our program lasts for 6 months. You go back to your family physician, internal medicine or whatever, and if they're not focusing on it, you're going to fall off the wagon. We all do. We rely on that physician to keep us honest with our lifestyle changes. keep asking those same questions. So you're hopeful that you're going to a physician who's going to keep up the battle with you and be your partner in it. That's what we're hopeful, that they'll be our partners. And we send them a letter and we suggest this, this, and this. And sometimes they're right on top of it, and other times they're not. So I would try to understand that you might or might not have it, and if you do have it, work with it, but then work as a team with your primary care physician and that office team. There's one thing that I forgot to talk about, none of us have talked about, and that's young women with polycystic ovary syndrome, PCOS, who generally have a little more body hair than they would like, and they very often don't go through appropriate ovulation because of cysts on their ovaries, and very often can't have children. But if it's recognized early, many of them do. What I'm getting at is polycystic ovary syndrome is associated with a metabolic syndrome. So if a teenager has polycystic ovaries, their primary care physician should continue to watch for hypertension, for prediabetes or diabetes, overweight, because that's one of the things that we treat in the program. Metabolic syndrome from polycystic ovary syndrome is treatable. We can do a lot with that cohort, and we probably at all times have about 10 or 15% of our patients in the program who have polycystic ovary syndromes as the reason for being in the program.
Thank you for catching that too. So that just about wraps up our live chat for today. Thank you to our panel of experts. Thank you to the viewers who tuned in for this. And have a good afternoon.